inside the kidneys, we do have microscopic structures that we refer to them as nephrons. The beginning of nephron is called renal corpuscle. So here I'm pointing at the renal corpuscle, and I see attached to renal corpuscle we have the rest of nephron, which would be a very long tube, and we call these renal tubule. In the next image, I'm looking at the renal corpuscle, and now I see that here I have a capsule that is called Bowman's capsule, and deep inside the Bowman's capsule we have a network of capillaries. We named the blood capillaries that are deep inside the Bowman's capsule glomerulus. And then we notice that there is an arteriole named afferent arteriole that sends blood into the capillaries, the glomerulus. In the wall of afferent arteriole, like any other arteriole, we do have smooth muscle cells. However, the smooth muscle cells that we have in the wall of afferent arteriole are unique. They are specialized, and we refer to them as juxtaglomerular cells. What makes these juxtaglomerular cells, the smooth muscle cells that we have in the wall of afferent arteriole, special is their sensitivity to any changes in blood pressure. For example, if the blood volume that flows into afferent arteriole is low, which that would be translated to a low blood pressure in afferent arteriole, and basically at this moment juxtaglomerular cells do not detect that much blood pressure, that's the moment they quickly release a hormone named renin into bloodstream. So the stimulus that makes juxtaglomerular cells to release renin into bloodstream is low blood pressure. As soon as they detect the low blood pressure in afferent arteriole, they release renin into blood, and renin inside bloodstream looks for one of our plasma proteins named angiotensinogen. When we say angiotensinogen is a plasma protein, clearly it means that this protein has been built by liver cells. Liver cells produce angiotensinogen and release it into blood plasma. What renin does, renin breaks down angiotensinogen into smaller peptides named angiotensin 1. And then when blood flows through our capillaries, including those capillaries that we have inside our lungs, an enzyme named angiotensin converting enzyme gets the opportunity to change angiotensin 1 to angiotensin 2. And now we follow angiotensin 2 and recall that angiotensin 2 must get involved in processes to increase the blood pressure. Recall that our story started when juxtaglomerular cells detected blood pressure is low, so the result should be an increase in blood pressure. This is a negative feedback system. When we follow angiotensin 2, we see that one of its effects would be on especially the arterioles that we have in skin and abdominal viscera to constrict them and increase systemic vascular resistance. We know that when systemic vascular resistance increases, blood pressure increases. Another effect of angiotensin 2 would be stimulating the cortex of suprarenal glands. When adrenal cortex is stimulated by angiotensin 2, it releases a hormone named aldosterone into bloodstream. And we see that both angiotensin 2 and aldosterone eventually get back into the kidneys, and what they do, they use different strategies to reduce the volume of urine. Basically, they make nephrons in kidneys to send more water back into blood instead of eliminating the water, and that leads to an increased blood volume and increased blood pressure. However, the parts of nephrons that these two hormones have their effect on would be different. For example, when I follow angiotensin 2, I see one of the places that it has its effect would be on afferent arteriole. When cells in the wall of afferent arteriole receive angiotensin 2, constriction, narrowing down of afferent arteriole happens, and when afferent arteriole narrows down, clearly that means less blood flows into these capillaries, into the glomerulus. And that decreases blood hydrostatic pressure inside the glomerulus, which simply means the rate of filtration slows down. And when filtration rate slows down, that basically decreases the urine volume. It simply means that the blood volume is increasing. Blood pressure is increasing. So we say angiotensin 2, by constricting afferent arteriole, decreases the rate of filtration in the nephron, and that leads to decreasing the urine volume and increasing the blood volume. Another part of nephron that angiotensin 2 affects would be the beginning of renal tubule, which is called proximal convoluted tubule. When we have a closer view of proximal convoluted tubule, we see that cells that line proximal convoluted tubule, by receiving angiotensin 2, increase pushing sodium ion and water back into bloodstream. Basically, we say in proximal convoluted tubule, by receiving angiotensin 2, reabsorption of sodium ion and water would increase. And when we're sending water molecules back into blood, that simply means we're adding to the blood volume. Please recall, water follows the solute. So increasing reabsorption of sodium ion stimulate an increase of reabsorption of water. Now, when I follow aldosterone, I see that aldosterone does not affect afferent arteriole or proximal convoluted tubule. Aldosterone affects part of the tubule named late distal convoluted tubule and collecting duct. In a closer view of late distal convoluted tubule and collecting duct, we see that by receiving aldosterone, reabsorption of sodium ion and water would increase in both these two locations, which we know that when more water molecules go back into blood, that increases the blood volume. So in short, both angiotensin 2 and aldosterone reduce the volume of urine. However, what they do, they affect different parts. Angiotensin 2 causes vasoconstriction of afferent arteriole and increases sodium ion and water reabsorption in proximal convoluted tubule. Aldosterone, on the other hand, increases sodium ion and water reabsorption in distal convoluted tubule and collecting duct.